I am Alyse Bedell. I am a GI psychologist, and I work at the University of Chicago Medicine. Just a big thank you to the Crohn's and Colitis Foundation and to the planning committee for inviting me to speak here today. I am going to be talking to you about psychosocial issues related to inflammatory bowel disease. So I appreciate Michelle giving kind of a shout out to the field, but many of you may not be well aware of the field of psychogastroenterology. So before I launched into the presentation, I just wanted to start with more of a formal introduction to what that field is. So first off, you can see at the top in orange is the field of clinical psychology. So that is the only field of psychology that is related to actually doing psychotherapy with patients. If you've heard of cognitive psychology or social psychology, those are domains of psychology that are purely research related. So individuals who get PhDs or PsyDs, there are two primary degrees here, are both doctoral degrees where people are trained to some extent, also do research, and some people do a huge amount of research, but they are also degrees that allow people to do clinical practice, so to do psychotherapy with individuals. So clinical psychology, I'm sure, as you know, can be very broad. It oftentimes is thought of being related to treating individuals who have mental health conditions. But within clinical psychology are a variety of specialties, just like you can see for fields of medicine. So within clinical psychology, people can choose to specialize within health psychology, which includes the practice of working with individuals who primarily have medical conditions. And within that, a person can subspecialize. Some people may choose to stay as a more generalist health psychologist, working with patients with a variety of medical conditions, but people can then choose to subspecialize if they want to. So psychogastroenterology is the formal name for my field, the field that pertains to working with patients with gastrointestinal diseases. And that can be, again, seen through more of a research perspective or clinical perspective. This field of psychogastroenterology has really been around for decades. Early practice was really done by some psychiatrists, some gastroenterologists, even those who are very psychosocially minded. But it's really been in the last several decades that psychologists have really taken up the work in this field. And today it's primarily work that is done clinically by GI psychologists, but I will note that there are some master's level clinicians, typically licensed clinical social workers, that work in this domain as well. So if you're curious about the existence of a GI psychologist or a gastropsychologist, we sometimes call it, and wondering why that's a thing, well, we can really see that based on the existence of the gut-brain axis, if a patient is only being treated by their GI medical team and the treatments are really only related to their GI tract, we're missing half of this very important puzzle. So the gut-brain axis is this very real, very tangible, bidirectional communication path that exists between the enteric nervous system, which is the guts nervous system, and the central nervous system, the nervous system of our brain and our spinal cord. It involves a variety of different physical systems, however. It includes the microbiome. In fact, some people now call it the gut-brain microbiome axis. I just think that's too long. And it involves the neuroendocrine system and immune systems. So what we are experiencing in our gut does get communicated to our brain, and what we are experiencing in our brain does get communicated in our gut. This is relevant not just for individuals with IBD, and not just relevant for individuals with GI conditions, but this is just relevant for all human beings. And in fact, this is something that I regularly remind my patients of. It is not just folks who have gastrointestinal conditions that have a gut-brain axis. So this is why in the English language, we have expressions like, oh, that was a punch to the gut when I heard that news, or I have butterflies in my stomach. It's because this is just a very human process. It's just that for folks who have inflammatory bowel disease or really any other digestive condition, this relationship becomes very relevant. And in fact, this relationship can get kind of enmeshed. The gut and the brain can communicate too closely. So that's really where the role of a GI psychologist comes in. So just to kind of zoom out and talk more about psychological and social issues more broadly in IBD, I wanted to scan out and to talk more about a variety of those issues. So you can see here, I have a number of things on this list. What I want you to notice is that some of these I'm calling a psychosocial issue, but it's also a physical medical issue or just a health issue, right? Like fertility. But the point of it being on this list is because there are really strong psychological and social implications here. So you can imagine that as these issues that I presented here become issues for our patients with IBD, it becomes really important that they have more of a psychosocial specialist that they can talk to help them deal with these issues. So I did put just a quick reference for anxiety and depression, how common those are in our individuals with IBD. These are some of the more recent rates. And I'm going to discuss not all of these in detail, but I'm going to go through a handful of these in more detail that I think are really relevant to your clinical practice. So I'm going to start with depression. Now, I think sometimes people find this surprising that I'm putting something that seems so basic on a slide like this. I know that you're all professionals, but what I'll say is that even professionals sometimes need a refresher on what these types of constructs are really referring to and what they aren't referring to. So when I'm talking about depression, I'm really referring to a persistently depressed or sad mood, or it can be really not a big change in the patient's mood, but it could just be a loss of interest in activity. Some people describe it as not really feeling much at all, not really feeling, although they might not feel sad. Some common symptoms that you might see would be having difficulty sleeping, having changes in appetite, hopelessness, guilt, difficulty concentrating, and suicidal thoughts. The diagnoses that would be related to depression are going to be most commonly a major depressive disorder, or an adjustment disorder. I talk to many folks who are medical and nursing providers who aren't familiar with that diagnosis of an adjustment disorder. It is a mental health disorder. It's a milder diagnosis than giving someone a depression, clinical diagnosis of major depressive disorder or a specific anxiety disorder. And it really speaks to when patients are having this abnormal, that's very subjective, of course, but an abnormal adjustment to a stressful experience in their life. So this is one of the most common diagnoses that I actually give to my patients with IBD that I'm seeing in my practice. So many times they actually don't meet full criteria for major depressive disorder. They really are experiencing a difficulty adjusting to a new diagnosis, to a flare, to whatever situation may be coming up related to their IBD. If we do look at depression more specifically, about 25% of people with IBD do struggle with the significant depressive symptoms, although again, that may not mean major depressive disorder per se, but clinically significant symptoms. But that number gets a lot higher when we're looking specifically at patients who have active disease, so about 40%. When you are looking for symptoms of depression in your clinic visits, I want you to just look up to the right corner here. These may be your patients that are more likely to miss their appointments, to exhibit anger or irritability or sadness in the visits. They may also be more likely to miss your phone calls or to not read the messages that you're sending in the EMR. And they may also be your patients that are having difficulty adhering to their medication regimen. Now let's talk about anxiety. So anxiety in this context is really just talking about an emotional state that is characterized by physical tension, worried thoughts, and other types of physical changes in the body. So common symptoms of this could include a sense of nervousness or irritability. GI upset is a symptom of anxiety, even among people that don't have a GI condition, and things like sweating. Similar to how I presented depression, a common diagnosis would be a generalized anxiety disorder. That's really when a person is experiencing worry about anything and everything in their life. That is not just anxiety about their IBD. But again, more commonly, what we might see here would actually be an adjustment disorder. It would be patients that are experiencing a lot of worries, a lot of these physical symptoms, but it's really that these worries are specifically related to their IBD experience. They're not so much worried about their job. They're not worried about their family. They're not worried about travel or if their cat is lonely while they're at work for the day. It's really that the worries center around their IBD or how their IBD impacts those other domains. About 33% of people with IBD do struggle with that more generalized anxiety, and that gets a lot higher when we're looking at patients with active disease. It gets to about 60%. So again, how might you spot symptoms of anxiety in your clinic visit? It might be those patients that just simply look and act more nervous, jittery, overwhelmed. They might be folks that are talking a lot that it's hard for you to get in a word in edgewise. They could be your folks that are doing a lot of excessive online researching. But again, importantly, these are probably folks that you'll find are worried about everything. It's just that you are in a visit about the IBD. So odds are they're going to be talking about the IBD more. You might want to ask, how worried are you or how anxious are you about other things in your life if you're trying to better understand how specific this is to the IBD versus how generalized it might be to other domains. They're likely to have elevated blood pressure. You may need to repeat some of their vitals at the end of the visit once they're a little bit more calm. They also may be more likely to avoid phone calls or medical appointments. A lot of times we think about this being that they are avoiding anxiety that they expect to have when talking on the phone with you or when sitting in that appointment. They kind of feel like they can protect themselves from the anxiety if they just kind of bury their head in the sand. I would say this is a little bit peripheral to generalized anxiety. This could actually be a phobia. It could be a different type of a related anxiety disorder, but patients could have a needle phobia or pill swallowing aversions. And so these also might be things that you could see among your patients that would be similar to an anxiety presentation. Now I want to zero in more on that GI specific anxiety. Now, this is not a specific diagnosis. It's not something that you're going to see in our DSM-5, which is how we diagnose mental health conditions, but it's a construct that is very well known, very well documented, and is going to be really the most common thing that I would say I treat in my clinical practice. So GI-specific anxiety is specifically relating to the fearful and anxious thoughts and behaviors that are related to GI symptoms or the context in which they occur. So you can think about these in two domains. One is worries, one is behaviors. So worries in the IBD population might look more like, oh no, why is my poop that color or that shape? We want to sort of read between the lines here. It's not so much about the color or shape that's concerning. It's this perceived meaning that change in color or that change in shape means something dangerous is going on. And you might have to kind of read between the lines on that. Might be a worry like, if I have to have surgery, my life is going to be over. Or it could be something like, I'm having belly pain, so I better play it safe and skip that dinner tonight. Or maybe I better get myself started on some of my prednisone that I have left over and see if that calms things down. Behaviors, so it could be excessive EMR messages, phone calls, researching symptoms. It could be patients that are trying their best to control their situation by having a very highly controlled diet, maybe a sort of highly controlled toileting routine. But again, it could be those patients that are doing more of that avoidance related to this GI specific anxiety, where they're actually avoiding their medical appointments or testing. So briefly, let's talk about disordered eating as well. So disordered eating, again, this in and of itself is not a clinical diagnosis, and it's not the same as an eating disorder, which is a clinical mental health condition. Disordered eating is really just a term that refers to anything that falls outside of the norm related to eating and diet. So it could be restrictive eating, compulsive eating, or irregular or inflexible eating patterns. Although I wouldn't say this is as common in IBD, binge eating is an example of a type of disordered eating. Disordered eating is not necessarily fueled by body image concerns. So we see it a lot in our IBD population that they may not have any issues related to their body, but they're doing this more as a way of coping with their IBD. And it can be motivated by fear and anxiety related to eating certain foods, or again, like I said, this perception of control, wanting to have something that they can do themselves. And when severe, this can become a clinical eating disorder. That could be a clinical eating disorder like ARFID, avoidant or restrictive food intake disorder. You may, if you're new to this field, you may not have heard much about this yet. You soon will. ARFID is getting a lot of attention in the really GI field more broadly, including in IBD. But I do want to call attention to the fact that it is certainly not just ARFID that can impact our patients with IBD. they can be susceptible to developing any type of eating disorder. And so I think it's really good to just kind of keep that broad awareness that any type of eating disorder could be possible as well. So body image concerns, pretty self-explanatory. These are really persistent negative thoughts and feelings about one's body. In IBD, we really see this related to a number of things. Most commonly, it's going to be weight loss or weight gain that is going to make people more self-conscious, of course, related to post-surgical changes, post-steroid changes, you name it. It can be patients that are adjusting to surgeries such as an ostomy or even fear of having an ostomy. And then, of course, embarrassment about bowel issues will fall into this domain as well. Now, sexual dysfunction is an area that's really important to me, so I always like to make sure to talk about this one. Problems that occur related to any part of the sexual response cycle that can decrease satisfaction with sexual activity. So the common things that you might see among your patients, men or women, could be painful intercourse, experiencing a low libido, difficulty with erections, or an inability to have an orgasm. Now, as you can see in IBD, the rates range very widely. In one study, rates of sexual dysfunction in women with IBD range from 49 to 97%. And in men, rates of sexual dysfunction range from 14 to about 40%. I do want to note that in this study, this was done in patients who were very newly diagnosed within the first year. And it was also using a very broad definition of sexual dysfunction, which again could mean a lower libido than usual. So it's not to say that these individuals may not have subsequently improved on their own, they may not have needed treatment, but it's really important that patients are aware that this can be so common, so that A, they're aware it may improve on their own, or B, they're aware that they might need help for it to improve. So how does this present in clinic? Well, I would say it rarely does, because we have lots of research showing that we actually hardly ever talk about in clinic visits. But when we do ask, the kinds of things that we'll likely hear about will be that their sexual symptoms may seem like, whether they are or aren't, they might seem like they're a side effect of a medication. They may seem to be related to embarrassment about having bowel symptoms. They might be related to self-consciousness about scarring or new anatomy. And oftentimes it's simply that pain and fatigue are getting in the way with interest in being sexual. So now I want to talk about trauma. So when I'm talking about trauma here, I'm talking about post-traumatic stress or the actual clinical post-traumatic stress disorder that is really due to medical illness or treatment. We sometimes refer to this as medical trauma. Of course, I want to point out what might be obvious, that our patients with IBD are just as susceptible as anyone to having a history of other trauma, car accidents, abuse, neglect, sexual assault. But what we're really talking about here is this increased risk that they experience that's really trauma related to the IBD itself. Trauma symptoms fall into four main domains. One is re-experiencing, that includes having memories about the trauma, having nightmares, flashbacks, feeling like you're right back there in that hospital room. Exhibiting avoidance, so trying not to think about the trauma that happened, or saying, you know what, I can't go back to that hospital where I had that uncontrolled pain for a long time. I just can't handle it. Negative changes in thinking and mood. This could be where patients are experiencing symptoms of depression, but related to really resulting from the trauma. And an increased arousal. This could be like having difficulty sleeping or an exaggerated startle response. And I'd say that this is an emerging area of research in IBD specifically. And a couple of pretty recent studies were done that showed that a third of patients with IBD scored above the clinical cutoff in a gold standard screening measure for post-traumatic stress disorder. And a subsequent study showed that almost 10% met criteria for IBD specific post-traumatic stress disorder using the DSM criteria. So we have reason to believe that we should be mindful of this in our patients with IBD. So on the right, again, what does this look like in your patients? Well, it may look like individuals who are declining treatment. It may be those who are avoiding hospitals or clinic spaces. It may be, again, folks who are not responding to phone calls. It might be people who are actually exhibiting anger. They could be jumpy, easily startled, and they could act mistrustful of providers. And so I oftentimes find that folks that I'm working with who I have a high suspicion of more trauma-related symptoms are ones that can have pretty disruptive relationships with their medical team. And that may not even have anything to do with the current team. It may be related to perhaps an outside hospital system that they were being treated at first and had some negative experiences and then came here. I also want to point out that sometimes these are patients who do have reason to feel mistrustful of their providers. These are patients that sometimes have had some really difficult experiences. And sometimes this trauma occurs of no one's fault, but the patient may still blame their medical team for what happened. So I want to talk a little bit more about how you assess these issues. So the first thing I would say, and I really think it's the most important, is to just utilize the clinical interview or the conversation that you're having with the patient in your appointment. So having a conversation where you open up the floor to check in about their well-being really validates the patient concerns, and it very much supports building that relationship. It allows you to provide strategies when possible, but it also may be important that you set up another appointment to discuss things further or provide an appropriate referral if needed. So what I want to say here is that it is not just because you ask about a psychological or social issue does not mean that you have to be the one that treats it. And it does not mean that you have to have a strategy totally fleshed out by the time that the patient leaves the appointment. That being said, it may necessitate that you have a sooner follow-up to continue the discussion. So when I am saying that this is something that you could talk about in the appointment itself, simply through conversation, I'm talking about some basic questions. One, how are you coping with everything? You've had a lot going on, you're facing surgery, or you're starting a new medication, or you mentioned that you're having to take time off work. How are you doing with all of this? You might also get a little bit more specific, and sometimes you might need to, particularly for patients who are a little bit more reticent to open up. You might need to say something that we'd call normalizing, to say something like, a lot of people, many people with IBD experience changes in areas of their life related to their illness. You might give a couple of examples then, like changes to eating, sexual functioning, or increased fear or anxiety about their illness and what it will mean for their lives. Have you noticed any changes like this? So that kind of gives the patient permission that they can open up. Now, I'm commonly asked to talk about self-report measures, and these can be very helpful. It's just that there are some there can be some logistical challenges to implementing them. So it's something that's oftentimes difficult to do on your own. It's usually better to do kind of as part of your whole team to make the decision to use self-report measures. But using self-report measures can be a very quick assessment of psychological distress. It can be a nice, easy reference for how severe the patient's symptoms are of depression and anxiety, because these questionnaires have ranges of typically minimal, mild, moderate to severe. And it's nice that it also allows for seeing changes over time. So if you were to give some of these questionnaires at every visit, you would be able to see, it looks like last time, you were at a 2 on this questionnaire and today you're at a 17. It seems like you're really struggling a lot more with depression recently. Tell me more about that. So to give a couple of examples, I'm giving the ones that I really think have the highest clinical utility. So these are the ones that I use in my practice. So for depression, the one that has the highest validation in IBD is the Patient Health Questionnaire 9. You're probably familiar with this especially if you've worked in the kind of primary care settings. So again, this has that mild, moderate, or severe range. So it's very easy to use. You do need to keep in mind that the 9th item on this is a suicidality question, and so it's really best to give this questionnaire in live time rather than sending it to a patient in advance, because reviewing that questionnaire in live time, you wouldn't be able to provide the associate resources if the patient was in immediate danger to themselves. But there is an 8-item version that just omits the ninth item if you feel that that's not easily integrated into your practice. And for anxiety, I use the GAD-7. I just think that has very high clinical utility, 7 items, very similar structure to the PHQ-9. But actually, it's the PROMIS anxiety questionnaire that I have below that was shown to have the highest validation in IBD. So that's one that can be considered as well. I just find it a little bit more difficult to score, and clinical utility is actually just a little bit lower. So probably better for using that in a research capacity. So what do you do when you spot these psychosocial issues? Well, first, I want to talk about how you might refer a patient if you think that they need more of a professional treatment. And so I want to distinguish between 2 broad types of psychotherapy. One is brain gut behavioral therapy, or sometimes I just refer to it as GI focused psychotherapy. That's the work that I do, really work that's more related to the IBD related concerns. But there's also general mental health therapy, psychotherapy that could be done by many qualified mental health professionals. And there is a difference between the 2. So if a patient is being referred to me as a GI psychologist or gastropsychologist, what they really should be most related to are helping the patient actually work on their GI symptoms. If the referring provider and myself think that they might be related, that there might be a psychosocial relationship with their symptoms, where, for example, stress or anxiety might be making their GI symptoms worse. And it could be coping with or adjusting to these IBD related concerns. What wouldn't be appropriate for a referral to someone like me would be working with a patient that has other life stressors going on, family stressors. If they have a long-standing history of a major depressive disorder, anxiety, or other mental health conditions, or someone who's really needing more specialized treatment for substance abuse, eating disorders, or PTSD, things like that, for example. Of course, it's very possible that individuals with IBD might have some of both going on. And so in those cases, again, if you have access to a GI psychologist, whether that's in your own practice or whether that's connecting with someone in the community that might do that work in private practice, you might need to run the situation by the GI psychologist and ask for their thoughts, or you might just say, would you be willing to evaluate this patient? I'm not quite sure what this patient's needs are right now. I think it might be more related to the IBD. I also want to just talk about what I would just call the therapeutic GI clinic visit. This is the work that all of you are doing in your visits. And my guess is that in this case, I'm really just sort of highlighting what you're already doing in your practice that is therapeutic and that is helping with these psychosocial issues. So really not downplaying the importance of body language. And these are things that I hear from my patients as they tell me about their GI medical visits, that, having a provider that does their best to maintain eye contact, that leans in, these are things that really make the patient feel like they are cared for and being listened to. I find that patients at this point, and many of you are probably finding this yourself, they're not as bothered by the taking notes while talking, but it is the difference of being able to take small breaks and look at them. It is sort of knowing if something's a really sensitive topic, taking that moment to take your hands off of your computer to make eye contact with them. So a little bit can go a long way here. I want to also specifically talk about 2 therapeutic techniques that you can absolutely do in your clinical practice and you may be doing already. So validation sounds really simple, but it's very powerful therapeutically. It's just to simply echo what the patient is saying and communicate that you understand the significance of it. You are validating their concern, you're validating their suffering. One simple way that you could say this would be something like, I hear how much this is impacting your life, right? I hear how much you're suffering. I'm here to help. I hear you. Normalization, I mentioned before, that's just to sort of help a patient not feel so alone, not feel so weird, to feel like even among patients with IBD, this is a common experience that patients that I work with. And so to be able to say that, I oftentimes use the example of a patient that I had worked with IBD. that I had recently started seeing for GI-focused psychotherapy. And he had had a diagnosis of ulcerative colitis for, I think, probably well over 10 years. And I was the first person to actually tell him kind of plainly that incontinence is a common issue in ulcerative colitis. And it was one of those things that it was probably said in passing, but it just wasn't said directly, or it wasn't in a space where he was able to take that in. But it was extremely therapeutic for him to hear that this was a common experience. It's not something that he was struggling with alone. Education, I think, is really important to point out here. And I think this is something that in my daily practice, I think I am very commonly kind of re-educating my medical and nursing colleagues on, is that it's not always about a referral to me to be able to help address a patient's anxiety. Sometimes it is about helping the patient craft very important targeted questions so that they can get the information that they need. And sometimes it's just good education that can really help to address their anxiety. So when I am working with patients, I help them with this by spending time in our sessions, helping them prepare for their upcoming clinic visits with any of you all. And so helping them say, all right, what are all the worries? What are all the questions that are going over in your mind lately? Let's just start to create a list of those. And then I will work with them on distilling that list down, helping to clarify it, and then having them bring that with them to their medical appointment. The benefit of them working with me is that then I can also give the medical or nursing provider a heads up. Okay, this patient is going to see you. Here is their list of questions, just so that you have a heads up. And then I can help educate the patient and the provider that after a lot of those questions are answered, if the patient is continuing to ask those same questions over and over, we would actually identify that more as an anxiety-driven behavior that we call reassurance seeking. That is more about trying to seek reassurance and trying to assuage the anxiety about the unknown, when in fact, the information has already been gathered. At that point, the reassurance seeking is really going to be something more that I'm going to be working with them on. I also want to kind of give a shout out to the importance of thinking about trauma-informed care. And so trauma-informed care, I would say, is kind of different conceptually from the slide that I was talking about, trauma and post-traumatic stress disorder. Trauma-informed care is really consistent with this idea that we, as all providers, need to be thinking about all of our patients having had an experience of trauma, whether that could be, I would say in an IBD setting, that could be assuming that all patients could have an experience of non-IBD related trauma, or assuming that all of our patients probably have some amount of IBD related trauma. It's not so much saying that you need to assess every patient for trauma history when you meet with them, but it's thinking about, if I knew that this patient had a trauma history, what would I want to do? And then doing that with every patient. So it means being very mindful about getting consent before you do an exam, about walking through every step of an exam or a procedure as you do it so that they know exactly what to expect. But it also may mean going a little bit over and above. And so specifically, for example, if you are going to do a rectal exam for the first time with a patient, really good idea to just double check, is there anything about your history that might make this exam harder for you? I don't need to know the details, but it'd be helpful for me to know so that I can help to really keep you comfortable and emotionally safe. So what are some of the other things that you're doing more specifically when it comes to providing education? So it could be educating all of your patients with IBD about the gut-brain axis, helping them understand that it is totally normal and natural that the gut and the brain communicate, and thus there is this strong relationship between their mental health or any of these psychosocial factors and their IBD, and that sometimes those can be working together really strongly. And this is when you might need more help on the brain side. That means giving a good explanation of why you might be recommending a psychological evaluation and treatment. And remember that education should be a bit different if you are referring them to work with a GI focused mental health provider like myself versus if you were referring them to work with a depression or anxiety specialist, for example. And just being honest and open about what the purpose is of that referral. You all may be in a position where you prescribe some central neuromodulators. If you're new to this terminology, that is the more commonly accepted terminology for prescribing things that maybe are in other settings used as antidepressant medications, but when they're being prescribed to address pain or ongoing GI symptoms. Of course, we see this a lot in our patients with disorders of gut-brain interaction or functional GI disorders, but these are very commonly used in our IBD patients as well. And so even just knowing that terminology, that instead of calling it an antidepressant, really, this is a central neuromodulator. It is something that is really going to be changing the way that the brain is communicating with the gut. And if it's true that you are not prescribing it to treat depression, you are really prescribing it to help with your GI symptoms, tell them that. A lot of times patients find it very helpful to know that these are medications that you wouldn't even be prescribing at a therapeutic dose to treat depression or anxiety. It's a much lower dose that can be therapeutic for these ongoing GI or pain symptoms. So I want to talk to you a little bit more about GI psychotherapy, or sometimes called brain gut behavioral therapy, so that you, again, if you are able to have a GI psychologist or other GI specialized mental health provider that you work with, you have more of a sense of what that work looks like. So there are a number of brain gut behavioral therapies that have a strong evidence base. What I'll say about this is that the evidence base is strongest for irritable bowel syndrome. That's where most of this research has come from. It's been growing a lot more in the IBD space, but a lot of the evidence we're really extrapolating from work that's been done in irritable bowel syndrome. But our two strongest evidence-based treatments and the most widely utilized on this list are cognitive behavioral therapy, or CBT, and gut-directed hypnotherapy. So those are the two that I'm going to be talking about today. So I want to walk you through this model or this cycle, and I'm going to explain it to you in just the same way that I do with my patients. And I'll also say that this is one very concrete way that I can help my patients understand that relationship between their brain and their gut. So in this example, let's say that this is a person that's experiencing belly pain, maybe after eating lunch. It's really normal that if a person is having some kind of stressful situation, like belly pain or any type of GI symptom, they're probably going to have some type of thought about it, right? A cognitive interpretation of their experience. A thought that I would be expecting in this case would be something like, oh no, the last time I had pain like this, I was having a flare, right? Well, what's the significance of that thought? It means the patient is fearful that this belly pain means that they're having a flare or that their new medication isn't working, for example. When we have thoughts, those are what lead to changes in our emotional state. So it's not so much, and again, this is how I explain it to patients, it's not so much that the belly pain itself directly resulted in anxiety, fear, and sadness. It's that this physical suffering was then compounded because of this cognitive interpretation, this assumption or this interpretation that the pain is going to lead to a flare or signifies a flare is leading to this change in the emotional state. Now, okay, why do we care about this emotional state? Lots of reasons. One is that, of course, even though these negative or uncomfortable emotions are not dangerous, they're not bad. In fact, we definitely need them to survive as humans. When we're experiencing them to a very severe degree, or we're experiencing them very frequently, they're leading to increased suffering and may even lead to clinical mental health conditions. It's also important that we recognize that these changes in emotion also cause changes in our body. And so this is where we start to introduce that our body's stress response. And so sympathetic arousal is what we call that. That is a branch of our autonomic nervous system that is really that fight, flight, or freeze response. Again, we need it to survive. The problem is that when we're experiencing stressful events all the time, which can be really common for folks with IBD, that stress response is getting activated very frequently. And so what that can lead to is actually worse symptoms. So not only does that stress response cause changes like increased heart rate, increased blood pressure, could be shaking, could be sweating, it causes changes in the GI tract. Now, again, that is not to say that those changes in GI functioning related to stress are dangerous, but they don't feel good. Unfortunately, those aren't changes that cause the belly to feel comfortable. Those changes cause the belly to feel more uncomfortable, and they can cause either more immediate or more chronic changes in the GI functioning. So what can that lead to? And behavior, really, I should point out, could go anywhere in this cycle, not just here, it could go anywhere, but it can lead to behaviors that are meant to address this symptom or the stressful situation, maybe missing work, maybe calling their doctor, maybe popping a medication to see if that helps. If this cycle kind of goes unchecked, that's where we would actually expect to see continued or worsening symptoms. And by symptoms in this context, I mean not only the GI symptoms may be worse, but the emotional symptoms may be too. So there may be increased anxiety, increased fear and sadness, maybe leading to more of a feeling of depression. And this is where we see the vicious cycle. So patients who are experiencing these kind of symptoms or these type of stressful situations on an ongoing basis not only experience this this cycle sort of in a like microcosm, but this can become a trend that is happening day in and day out, week after week, month after month. So this can be very helpful in them understanding how their mental state impacts their GI tract and vice versa. So when I'm using cognitive behavioral therapy as a primary treatment strategy, I'm really working with patients in typically short-term treatment, sometimes as few as 4 sessions, very commonly up to 8 sessions. But I will say here that longer courses can not just maybe, I would actually say they're oftentimes indicated in our patients with IBD in particular. A lot of times it can be quite difficult to wrap up a course of this therapy if the patient is in the midst of a flare, or if they have an upcoming surgery that I'm working with them on. So oftentimes we might have a more active course of treatment, and then we might taper off. Maybe we'll meet monthly or even every couple of months to kind of check in as they're moving through their treatment and hopefully getting back on top of their disease management. But that active treatment may be, again, kind of in that shorter range, under 10 sessions. But when we're using cognitive behavioral therapy as a primary treatment modality, we're really helping the patient optimize their thinking and their behavioral coping as a means of improving how they feel physically and emotionally. CBT really emphasizes psychoeducation and relaxation strategies. I teach diaphragmatic breathing to almost every one of my patients. But I would also say that the goals really vary a lot based on a patient's presentation and preferences. For example, in the last slide, I gave an example that was really focused on GI symptoms being part of that cycle. I'm sharing that with you all, and I share that with patients because oftentimes that's the piece that isn't actually as intuitive as recognizing how the GI symptoms can be exacerbated by all of this. But it's also really common that I'm working with a patient with IBD where there isn't a strong reason to think that these psychological factors are really driving these physical symptoms. They may, I'm sort of aware that they're in active flare and they really need to rely on their medical and surgical management. And then we'll see after that what symptoms may be remaining. So we may not have a strong emphasis on trying to address those GI symptoms. It might be much more about coping with their diagnosis, managing maybe family dynamics or people who aren't being supportive, a lot of health anxiety. And some patients I might work with simply because they're having difficulty working with their medical team. And so I might be doing a lot of interpersonal communication enhancement, helping them figure out how to navigate treatment with their existing team. Now, hypnotherapy is a treatment that, again, was really developed, gut-directed hypnotherapy was really developed for irritable bowel syndrome. Hypnotherapy, clinical hypnotherapy, has been really used for decades and decades and has been used for a variety of different, in a variety of different medical settings. But for those who might not be familiar, Hypnosis is a process by which a person enters a heightened state of relaxation and focused attention that's really making them open to therapeutic imagery and suggestions. And it's used in a variety of medical settings that really reduce or change their engagement with physical sensations. In IBD, it's very helpful for reducing hypervigilance and hypersensitivity, improving self-efficacy and relaxation. And then as we're wrapping up, I am not a pediatric provider. I'm an adult provider. I don't work with anyone really that's younger than 16. But there are GI psychologists who are pediatric. There's even fewer of them than there are adult professionals. But when we're thinking about pediatric populations, this is really going to be working with children and their families to learn strategies for managing their IBD. It's going to be about learning coping strategies, coping skills, and relaxation strategies to mitigate the effects of stress on the body. It's going to be about improving their social and occupational functioning, especially as it relates to school attendance, and then providing eventual support in that transition to self-management and adult GI care. I have included in my slides a number of resources for folks that are interested in learning any more about this, including if you're interested in getting trained in hypnotherapy. That is something that advanced practice providers are able to actually do with some additional training. And then some patient-facing resources. All right, so that is the end, and I'm happy to answer some questions.